to our December seminar for our Accords Sustainability, Value, and Cost series. We've already had a couple seminars in this series focused on understanding multiple levels of considering cost and sustainability in development of healthcare interventions and programs. Last month, we had a great talk from School of Public Health faculty member Marcelo Perlon on cost effectiveness analysis and thinking about patients' perspectives on cost and value. And this month we are joined by Dr. Doug Luke from the Brown School at Washington University in St. Louis to talk about sustainability from a public health and clinical setting perspective. And so Dr. Luke is the Irving Lewis Horowitz Professor in Social Policy at the Brown School at Washington University in St. Louis. He directs the Center for Public Health Systems Science, which focuses on public health policy research and evaluation. His work has focused in recent years on system science and implementation science. He's particularly interested in increasing the use of system science concepts and methods within implementation science. Today's talk, If You Build It, Will It Stick Around? Lessons Learned While Developing New Measures of Sustainability in Public Health and Clinical Settings, focuses on a common challenge that we've talked about in previous seminars around how do we assess sustainability? How do we think about sustainability and value from a practice and organization and system level perspective, as well as concerns about measurement. And so Dr. Luke will be talking about not just what measures currently exist, but where we might go in the field. We encourage everyone to make active use of the chat. We will be leaving at least 15 minutes for question and answer at the end of his talk. So please feel free to jump in at any time and ask your questions. We'll get to it in Q&A. Letting you know about some upcoming seminars. In January, we'll be learning about time-driven activity-based costing, or sometimes called micro-costing. So this is specifically a method that's used to understand costs and resources at the practice level for implementation of different types of healthcare interventions and programs. And for that, we'll be joined by Dr. Laura Panettone, who's at the Fred Hutchinson Cancer Research Center. So we hope you choose to join us for that. I want to make sure that I mention that we have an evaluation that will be coming at the conclusion of this seminar. We really do want to hear from you. We take into consideration all of your different ideas for future topics and for how we conduct these seminars. And we always archive all of our Accords Education sessions, and you can find that on our Accords Education website. It's easy to Google Accords Education and find not just this seminar, but really everything we've done in the past, I think, 5 years. So with that, I'm going to turn it over to Dr. Luke for his presentation.
Great, thanks, Bethany. Before I start talking, let me. Does that look good? Okay. Thanks again, Bethany, for the opportunity to virtually see you all and talk about sustainability assessment. I'm actually joining you from St. Louis, and I'm not on the campus. We don't go to campus anymore in these days of COVID, but it's nice to join you today. So Bethany did a really nice job of actually going over what I plan to present. And I'm not making too many assumptions about the group out there. I'm going to do a little bit of a conceptual introduction in terms of how we've been thinking about sustainability, then talk about two different instruments we've developed over the past several years for measuring sustainability, and focusing a little bit on that measurement development process and how we think about psychometrics and reliability, and a little bit about validity and why that's so important. And then I'll finish up with just talking a little bit about how these tools are used with community partners in both public health and clinical settings. So that's the game plan. We all have to deal with Zoom meetings these days. One of the things that I want to tell you up front is Much of what I'm talking about, further details are available at our website, sustaintool.org. And in particular, the most important thing is you can download the two instruments we're going to talk about, and you can also take them if you want. You can actually take the tools online. You might want to explore it during the talk. I know how hard it is to stay focused for even 30 minutes of a Zoom presentation. I'm not going to hop back and forth. I'm going to stay on the PowerPoint for the presentation, but feel free to explore the website. So let's start with the basic question, why sustainability, and why have we put energy into this here at WashU? Well, the work for us actually started, decades ago. We have a long partnership with CDC, in particular, the Office of Smoking and Health at CDC. And in the early 2000s, tobacco control programs around the country were being hit with pretty dramatic funding cuts. And we had been doing evaluation work for CDC, and they were quite both worried and interested in finding out what was going to happen to programs when their funding was cut. And that was the first time, certainly, that I started thinking about sustainability. And back in those days, there weren't a lot of frameworks or theories around sustainability. And even more than that, in public health, at least, there was an assumption that sustainability was equivalent to funding. That is, to sustain a program over time, you needed funding, and if funding was cut, the program would disappear. Well, we discovered that it wasn't that simple, and we sort of entered we started addressing this question when a lot of other people in public health, and I would say implementation science, started thinking about sustainability. In particular, this is a very simple conceptual model. It's essentially a pipeline model for D&I science that shows where sustainability fits in. That is, we spend a lot of time, both as public health researchers, public health evaluators, implementation scientists, thinking about what goes on here in this in this model. That is, we produce new evidence, which is needed by community partners, state and local programs, national organizations, policymakers, and so on. And in fact, those groups pull the evidence into their own worlds, if you will, as the scientists are pushing them. At the beginning of implementation science, I think it's fair to say that much of the focus, much of the interest in D&I was at this left-hand side of the model, particularly around dissemination and implementation, early adoption. The last number of years, I think there's been increasing interest in the right-hand side. That is, what happens after initial implementation. There's some people here at WashU who've been looking at things like de-implementation, like how do people stop programs when they don't work and shouldn't continue. What I'm going to be talking about, though, is sustainability, that is sustaining important, effective programs, because without sustainment of evidence-based programs, the public health benefits of programs and policies will not be realized. So when we started thinking about this, as is often the case, people argued a lot about what was it that we were talking about. What does this mean? And there was a lot of overlap between different terms. So this is how we think about this. And I'm just highlighting three terms here. One is sustainability, one is sustainment, and one is maintenance. And you probably have come across these terms in some of your work. When we started this, particularly the first two terms, there was a lot of confusion about this. And sustainment is the thing that we actually want to see. That is, we want to see an evidence-based program actually sustained over time. But sustainment turns out not to be a very challenging or interesting measurement issue. That is, to measure sustainment, you sort of look and see if a program still exists after a certain amount of time. Where I think the field has gone more is thinking about sustainability, which is the ability of an organization to maintain programming and its benefits over time. This is important for a few reasons. One is if we understand this ability or capacity, that allows us to do implementation better. That is, we can implement things with the hope that with high sustainability, actual sustainment is more likely to occur. So in our own work, we started focusing on what we called program sustainability, but this is really through a public health lens. So what we mean by programs are the programs and policies that communities, public health organizations, and the like are trying to implement, really, and sustain. And so here we have a very simple definition of program sustainability: the ability to maintain public health programming and its benefits over time, again, with the emphasis on the ability part. This is a picture of our conceptual framework that we came up with, and I'm going to talk a bit on how we came up with this. But for now, just notice that there's 7 different concepts, 7 different constructs here. And these are things that if organizations, if public health agencies, for example, have these things, then the assumption, our theory, is that they will have more capacity to sustain evidence-based programs. So funding stability, not just having money, but having a stable source of funding, having good partnerships that support the programming, having communications. I'll show you some examples of these in a bit, but the point is these are things that if you have more of this, it's going to be easier for you to sustain programs. Now, this is based on a number of studies. For example, we did some evaluations of tobacco control programs, and we found once, for example, that programs that had lost funding but had effective communications, and they communicated the results of their own program evaluations to interested stakeholders, were actually more successful at getting at least some of their funding back. That if they were able to tell their story about why their programs were important, those programs were more successful at sustaining their own programming. So each of these domains, I'm not going to go over these in detail, and that's why I suggest that you go to our website. But as I said, each of these domains has a definition. So, program adaptation is assessing your program to inform planning and documenting those results. And in theory, you would like to do well on all of these, but in practice, of course, that's never the case. The framework led to our development of an actual measurement system or a measurement instrument that we call the PSAT, the Program Sustainability Assessment Tool. And like I said, you can go to the website and download this. It's free. It's available to anybody. And this just shows you what it looks like when you're using the online version. And the basic instrument it's really simple. Each of those 8 domains has 5 items, and the 5 items are all measured and scored the same way. So for example, here under communications, there's an item called the program increases community awareness of the issue. And if you're rating a program, you would basically respond in a way that says, does your organization have this to no extent, or to a great extent? So the more you have it, the higher the number you would give. And then each of these subscales is scored, and you can get both subscale scores. So for example, there would be a communication score and a strategic planning score, as well as an overall sustainability score, which is actually not nearly as interesting or useful as the 8 subscale scores. Now, that was our first instrument, and with only a little funding, we were stunned by how well this took off. The PSAT has been used to rate thousands of programs around the world. Everything, and not just public health programs, it's used for education programs, social service programs, even clinical programs, which is going to be the next part of the story. And it's just been used a lot. And we've used it more formally and funded evaluation and research projects. And then people also just use it because it's available for anybody to use. However, what we discovered particularly was a lot of people were interested in using the PSAT, and they were applying it to clinical programming or clinical practices, and it wasn't a very good fit. You know, we designed the PSAT to be pretty broadly applicable, but it just really didn't work in clinical settings. And so, you know, we discovered a number of things. Basically, we discovered that we needed to develop a second instrument, the clinical sustainability assessment tool. And here are some of the reasons for this. You know, in clinical settings, you don't think about programs as much, but it's actual practices. The staffing in clinical settings is incredibly important for sustainability of these practices. These practices have to fit into very complex work settings. So, you know, a new evidence-based practice that doesn't work in, let's say, electronic health records is not going to be sustained because things have to be integrated in these settings. And so for all of these reasons, we realized we needed to essentially start over and develop a new instrument. And so we did that. And clinical sustainability, the sustainability idea is similar, but the context is different. And here our definition is, you know, clinical sustainability is the ability of an organization to maintain structured clinical care practices over time and to evolve and adapt these practices in response to new information. And here, our framework, we ended up with only 7 domains, 7 underlying constructs instead of 8. And again, though, it's similar ideas, but for example, we have a workflow integration, which I had already suggested. So in this case, if a clinical organization or setting has designed the practice to fit into existing processes, policies, and technologies, then we would expect there to be greater capacity for sustainability. So again, you can look at this on our website. This measurement instrument it was designed to parallel the PSAT. So measurement works very similarly. Each of the domains has a subscale. Each of the subscales has 5 items, and people are asked to rate whether their setting or agency has this particular thing to little or no extent up to a very great extent. And here, this slide is a nice way to show both the similarities and differences between the PSAT and the CSAT. And you see there's some similarities. So for example, both the PSAT and CSAT has an evaluation domain. For example, we have general partnerships for the PSAT, where partnerships aren't quite as important in clinical setting, although there still is the need for having engaged stakeholders. So I already mentioned how this can be assessed, but let me just add one more piece, and then I'm going to talk about how we actually develop these tools. One of the things that we've done on the website, and then we do if we work with partners, is when you do the assessment, when you rate your own program or when you rate your own clinical practice, there is a tailored feedback report that you can get online, which presents an overall score, the different subscale scores, and some other information about how you could use this information in, for example, program planning. Okay, so how did we build it? Well, this was, I already hinted that we didn't have a lot of funding for this, so a fair amount of it was by the seat of our pants. But we tried to be as systematic as we could be in this. And essentially we start we started with the conceptual development and, you know, a fairly traditional literature review. What I'm going to do here, since we talked about two instruments, the next set of slides is really focused on our development, our more recent development of the CSAT, but we followed a very similar process for the PSAT. But starting with the lit review, we use something called concept mapping, which is a mixed methods approach that's very useful for mapping out conceptual domains to help us come up with essentially the conceptual framework for the measurement. We then developed the instrument based on what came out of the literature and the concept mapping. We drafted an instrument. We did an initial pilot study, then finalized the instrument, focusing particularly on usability and reliability. And then we're sort of still working on this, which I'll talk about at the end. Many of you, I'm sure, are fairly familiar with concept mapping. I don't have time to go into great details here, but I really encourage, if you haven't come across concept mapping, it's a really useful tool. And one of the neat things is it is based on getting input from community members, experts, whoever is relevant, and it combines both qualitative and quantitative. It's essentially a fancy Delphi technique for helping to figure out what the right conceptual structure is. And for the CSAT, it starts with asking people to respond to a prompt. And the prompt is, for practices in clinical care to successfully continue over time, they need, and then people would respond to that and provide items. And we had, in our pilot, we had over 40 people, both clinicians and evaluators and researchers. And they ended up generating a lot. They were quite thoughtful. They generated a lot of statements. Then there's a sorting and a rating process that happens. And what you end up with, as the name suggests, is a conceptual map. And this was the final map. There's a lot of additional maps that lead up to this. But this is a type of a cluster analysis, which is based on sortings of individual items. Each orange dot here is one of the, I think we ended up using about 90 some items out of the 230. And as the labels suggest, these items fall into like a bucket. And so what we see here is all of these orange things here are about various aspects of what we ended up calling workflow integration. And the map tells us that these are really similar to each other. They're really tightly clustered. Whereas something like organizational context and capacity was a little broader. And in concept mapping, when you have items that are in the middle like this, that's not too good. But for the most part, this is a pretty clear and pretty stable solution. And so we felt comfortable moving from this to start developing the actual measurement instrument. There's other things that you can do with concept mapping. This is what's called a ladder plot. And in our case, all those items were rated for importance and feasibility. The idea being is when you think about stuff that is part of capacity for sustainability, you want it to be important and you want it to be feasible in that it's something that you can actually do or implement or change. And this gives you a lot of useful things. So for example, what we see, which one do I want to pull out? The green arrow here suggested that people didn't feel that organizational context and capacity was quite as important as some of these other things, but they felt like they had more control over that. They certainly feel like that changing organizational context was more feasible than, for example, workflow integration. All right. So as I suggested, we use this information to put together a draft CSAT instrument, and we were able to pilot test this. We ended up with, we wanted a little more than this, but we ended up with 126 people And this just gives you some information that we are trying to get a diverse set of people working in a variety of different types of clinical settings, had different kinds of patients. It was important that these characteristics were as diverse as possible. And what we found from the pilot is, first of all, the most important news is that it was usable. We designed this to be fairly easy to use. It's fairly short. The CSAT is 7 subscales of 5 items each, so 35 items. But because they're all the items are scored the same way, people can go through them pretty quickly. And participants agreed. The vast majority felt it was easy to use. They thought it would be, most people would be able to learn to use the tool quickly. They didn't think that it was unnecessarily complex, and that people didn't think they would need a lot of support or training. One of our design goals, by the way, was to develop an instrument that you didn't need a PhD to use. That is, we didn't want it to be just a research instrument. We wanted this to be used for evaluation purposes, continuous quality improvement, let's say, for example, in hospital settings. And so we were pretty happy when we saw this. In terms of how the instrument actually works, some of you may have some psychometrics training. For the rest of you, I'm not going to get into too much of the of the weeds, but there's a couple things that you really want to look at when you're developing a new instrument. And I would say, by the way, this kind of work is informed by my own background. I come out of clinical and community psychology, but I've been in public health most of my career. And I think it's fair to say that when people develop new instruments in public health, they often spend a lot of time thinking about face validity. They want to develop items that make sense, that people can understand, and that's really important. But they don't always think as much about reliability and validity as they could or should. And so, one of the things I hope you see here is how you can build instruments that are theoretically based, but you still without taking too much time and without costing millions or hundreds of thousands of dollars, you can establish reliability and validity. In our case, these are our 7 final domains in the CSAT, and you look at things like the scale means and the scale standard deviation because you're looking for problems like restriction of range, but for reliability, what these numbers here in the last column that I call alpha, this is Cronbach's alpha, and Cronbach's alpha is a reliability measure that assesses something called internal consistency. The idea here is the 5 items that are on engaged staff, they should be similar to each other and not that similar to the items that are in the other subscales of your instrument. And these alphas for 5-item scales are really quite good. These are numbers that the closer to 1, the better. And in the social and health sciences, typically, if you get above 0.7, you start feeling good. And certainly above 0.8 is excellent, and especially with the small number of items in these subscales. It's harder to get high internal consistency when you have short scales. So we were thrilled to see this. Internal consistency is one thing. It's the start. It's telling you that there's good intercorrelations between the items that make up the scales. But you remember what we're doing here was we base this idea on, well, I'll just stop here, that clinical sustainability has 7 dimensions or 7 domains. Now that's theoretical. When we started with this, it's not that we were making it up. There's literature that suggests this. Our concept mapping suggested it, but until you actually measure it, you don't know whether those 7 domains really work. And the table here comes out of something called confirmatory factor analysis, which is a really useful tool when you're doing measurement development. And you can build and test measurement models, sometimes they're called structural models. And and what you're seeing here is 4 different models that we built. The first model used our pilot data, and it starts with, you can think of this as our null hypothesis. So what if really there isn't 7 different domains? There's only one. There's something that it's like a good, bad dimension, or it's just a generic sustainability dimension, high, low. In that case, you don't need 7 different subscales. Then what we did is we tested a model where we basically took the same people and the same items and tested a model that has 7 subscales that correspond to our conceptual framework. And then I'll talk about the last 2 rows in just a sec. So the first 2 rows are telling us with these 3 sets of numbers that there's better fit with the 7 subscale model. That is, the 7 subscale model is significantly better than a model that only has 1 dimension. And we know this. I don't have time to, I mean, if people have questions about this, I'll go into details, but you want the comparative fit index to go close to 1, and you want the root mean square error of approximation to go lower, particularly below 0.08 or below 0.05. And what we see is the model with 7 subscales has a better fit. Our pilot was only 126 people, but people continue to start using the CSAT, even though we hadn't gotten our paper on the CSAT out yet. And in particular, we have 3 different projects that have been collecting data using the CSAT, and we're calling them early adopters because they really are the first real clinical research and evaluation projects to use it. And we are able to get another 166 people, or 166 cases. And the upshot of this is, now that we have a larger sample size, we actually have really excellent fit. So we feel confident that the 7 subscales are working. And there's another test that I'm not showing here, but we're able to test the model fit across these different samples. And there's good validity in the sense that the 4 different sources of data are using the subscales in pretty much the same ways. So that will hopefully, this last set of findings is I think what will get our paper published. So we're happy. Now, our development project really wasn't able to do any real validity testing, and certainly not any predictive validity testing. But we were able to take our CSAT scores and show that they were able to distinguish between different types of clinical settings. So what you see here is across the different types of settings, outpatient clinical settings across almost all, well, essentially all the subscales reported lower sustainability scores. We see some differences, not as large for patient type, but we see quite large differences between different types of environments, particularly private practice and community health centers tend to show lower sustainability than academic medical centers and community hospitals. Okay. I'm going to try to finish this up in the next 5 minutes. Let's see how I do. Now, for those of you in the audience who are researchers or evaluators, this last set of slides probably are of most interest. But I think many of you are thinking about how to actually use these. Like, where would you use the CSAT or the PSAT? Well, as I said, people are using it in many, many different ways, and we're actually not aware of most of the uses of it. But when we partner with either public health programs, or more recently, we're starting to work more in clinical settings, we tend to use sustainability to aid in a planning process. And so what we mean by that is when we work with partners, we start with, let's understand sustainability. Let's all be on the same page in terms of what sustainability is. then once we're there, you can use the tools, and usually people are using these tools integrated with other, other measures they're doing, or other instruments they're using. It's not the only thing that they're collecting data on, but they assess their sustainability. And then the most important piece really is use that sustainability assessment to do program planning. And with that, there's a few things we've learned along the way. First, the PSAT has 7 subscales, and the CSAT has, the PSAT has 8, and CSAT has 7. But no program can really work on everything all at once. And so in program planning, we suggest that you focus on what you can change. And this is an example where, well, maybe the environmental support and funding stability is just way above our pay grade, but thinking about our program, the rest of this is something that we might actually be able to move the needle on. And so when you get to program planning, then you'll focus on these and not all the domains of sustainability. We also talk about that these domains are obviously interconnected, and they're distinct in meaning, but when you work on one, they're going to have effects on the others. So for example, here, I gave the example of state tobacco control programs that communicated findings about their programs. Communicating those findings then affected their state legislatures, that is, the legislatures understood why their programs are important, and that in sort of a cascade effect resulted in improved funding. And so these are 3 of the sustainability domains that you can see how they might influence one another. I'm going to skip this for now. This is just an example of not a very attractive, but a useful planning document that we find that you want to start really writing things down, structuring it, setting up priorities, setting up timelines, because you basically want to take what you've learned from your sustainability assessment and say, okay, over the next year, this is what we're going to do. As an example of this, so with funding from CDC, we have been doing sustainability trainings and assessments with state tobacco control programs for, I think, the last maybe not quite 10 years, but for a long time. And I wanted to highlight the program from Louisiana. And they were particularly successful in doing their own program planning. And when they originally assessed their sustainability, it made sense to them. It laid out a framework that they could use, but they were particularly interested in working on partnerships because they felt like their partners hadn't received enough attention up to that time. And so they decided to do some strategic planning, and they actually connected their sustainability assessment with their formal strategic planning process that year. It just, it was sort of luck that the two coincided in time. And they asked us to come back after they had been working on this for a while. And what you see here are the changes in their sustainability scores over a 2-year period. And what you can see is some of the areas didn't really change that much. And in particular, they were the ones that identified initially that environmental support and funding stability wasn't going to be that malleable for them. And what you can see, though, in the other areas, there were pretty big changes, including partnerships, which is what they were particularly interested in. And they were really happy because they felt like the sustainability framework gave them a language and some resources that allowed them to break what many people think of as a big problem into smaller, more manageable chunks. And when they reported back to us, they said these are the reasons that it worked for them. And I already mentioned that the strategic planning and sustainability were aligned. They had champions that bought into this idea of working on sustainability. and they were able to engage stakeholders in this process. It wasn't just a small number of people that did it. And this is one of the things they told us, that in terms of what it meant for them and for their program. Okay, so I'm almost done here. And I just wanted to highlight a couple current things that we're working on. We're continuing, so PSAT has been out in the wild for a long time, and I mentioned it's been used for thousands and thousands of programs. CSAT is just getting out there, and we're working on some grants and some projects with groups that are interested in using CSAT. One of those projects is with St. Jude's Hospital, and they are doing a sustainability of some evidence-based pediatric cancer practices, and it's an international project. And so they were the impetus. We translated the CSAT into Spanish, which was the first time that we had done this, and it went really well. And so we went ahead and translated the PSAT into Spanish, and we may be essentially, if people are interested, there's actually a group that may want us to translate this into Vietnamese. And then the other thing is, we thought these instruments were, we think they are easy to use. It doesn't take that much time, but especially researchers, it's the researchers more than the community partners, but the researchers felt it was still too long. And we at first, we were reluctant to hear that, but then we actually looked at some of our data, and we're working on developing a short form version where each subscale has 3 items instead of 5, and there's actually good early results. We're just starting to look at this, but we think that we may be able to provide shorter versions of both the PSAT and CSAT pretty soon. Okay, so I've seen some things like flashing, and I was just hoping that I haven't been talking to the void for the last 40 minutes, but I'm at the end of my part. So if there's some questions people have or suggestions or want me to talk in more detail, I'm really happy to do that.
Well, thank you so much, Dr. Lucas. It's great. I learned a lot, and we do have quite a few questions. So I'll sort of run down the list here. And so Russ Glasgow asks, when you're talking about that definition of sustainability versus sustainment versus maintenance, what are we talking about? What's being sustained? Is it the program? Is it the outcomes, the capacity of the groups? I know you mentioned funding isn't the end all be all. Can you clarify a little bit like what it is that we're talking about sustaining?
Yeah, and I actually meant to, because I think you asked me to provide a couple like papers or resources for people, and I don't know if anybody looked at them, but one of the papers I suggested was Russ's paper with David Chambers on the dynamic sustainability framework, and I was thinking about that the other day, and it's essentially one part of an answer to Russ, which is we start with these concepts, and as I suggested, at least in the early days, there's not a lot of precision in those concepts, but the field has been working on this for a while, and now I think it's that the frameworks like CFR or the dynamic sustainability framework really are important because they suggest where we should end up, if you will, but they don't tell you how to get there necessarily, and that I think is what measurement development is about. Now, more specifically to Russ's question, I think we are for these instruments, and you'll see in the paper and the website, we try to be pretty careful here. These instruments are measuring capacity for sustainability. That is, as I mentioned before, actual sustainment, you don't need a complicated instrument for that. Now, the other part of his question was, what is it that's being sustained? That we leave pretty open. For some purposes, it's a very specific thing. For example, one of the early examples we did in the development of the CSAT was new policies for hand washing in hospitals. That is a practice that, hard to believe, but but it was a practice that wasn't formally developed in many hospitals until somewhat recently. And so that is a thing. That's a specific practice that you know, there's a new program to educate nurses and physicians, and how long does it last? Hopefully permanently. But people have used these instruments to develop, to assess things that are much broader. As I've already suggested, an entire state tobacco control program. Well, and people have assessed it, and we've done training on that, and it's worked really well. So these things can be pretty specific or fairly broad, but you need, this isn't going to satisfy Russ because it's not very sophisticated. But if you can name it, if you can point to it, then it's something that might be sustained. What by that I mean, it can't be like a general concept. You don't sustain, a value, like something like interdisciplinary science. That's not okay. Russ says he's satisfied. You don't sustain an idea or value, but let's say you had new promotion and tenure guidelines that introduced concepts of interdisciplinary work. That specific set of program promotion and tenure guidelines, you could measure sustainment of that. I hope that addresses some of that.
Yes. So another sort of clarification around definitions. So when we talk about program sustainability, I mean, what are we talking about? 1 year, 2 year, 5 years, 10 years? Can we not write our paper on sustainment until it's been around for 10 years? What sort of time frame?
And this was the, if you want to be cynical, you could say this is the bait and switch in our work. By saying that we're not measuring actual sustainment, but capacity for sustainability, you can measure capacity for sustainability at any time. In fact, the most valuable time to measure is actually before you implement something new, and then you follow it over time. And as you follow it over time, you can continue to measure capacity for sustainability as you're measuring actual sustainment. The real answer to how long you have to wait for sustainment, it just depends. It depends on what it is that you're looking at. It depends, a new clinical practice that will, one of the groups we work closely with is what's called antimicrobial stewardship. It's the putting programs in place that reduce use of antibiotics. And when you're introducing a new program like that, you will see clinical outcomes almost immediately. And you probably don't need to wait 20 years to see whether it's sustained or working. That's a shorter time frame. Other things like broader public health policies that change population health parameters, obviously you'll have to wait longer for something like that.
Thank you. So there's a couple different questions that are around this notion of adaptation and how does sustainability relate to overlap with to the concept of adaptation and adaptability?
So I don't think I'm going to have a very satisfying answer for this because notice if any of you go and actually look at the instrument, well, I'm not going to pull things up because we don't have a ton of time. The capacity for sustainability, the domains and the items are not very tightly tied to the thing that's actually being sustained. They are about the context for sustaining that. Again, remember this distinction that was important. Capacity for sustainability is different from sustainment of a program. So what gets adapted? Certainly in the way that I think Dave Chambers and Russ talked about this in their paper, it's the intervention, it's the practice, it's the program that gets adapted. And so there's a pretty sharp line between that, but where the connection is is, and this is another concept from their paper, is alignment. Alignment of they talk about one of the reasons you need to have a dynamic framework, and I may be butchering this, by the way, but my take from the paper was one of the reasons you need to really have a dynamic framework is because that alignment between the intervention or what you're implementing and the context in the organization itself is quite dynamic. And so one of the reasons you actually have to adapt the program or practice is to improve that alignment. There, I think our PSAT and CSAT are really valuable because they are going to help you assess that alignment. I mean, that's the thing. I mean, what their paper did, it was the go west, young man sort of direction. But what we need more of is like, well, how do you measure alignment? You know, if alignment's important, you need to measure it. And I think the PSAT and CSAT tools are not designed to measure alignment per se, but they do give you enough information about the organizational setting and capacity that you could use that to be thinking about alignment in your own program planning.
And would you relate that to your recommendation to assess sustainability early and often, that part of what you're looking at is that change over time?
Yeah, in fact, that we found, you know, we didn't even know if people would do it once. But, you know, once, I think what we found is when groups and programs find value in it, it's actually an easy sell. And for most things, you know, annual assessments seem to be right. You know, if you're doing program planning, it takes time to nudge the needle on these things. You know, you're not going to see real changes in a week or a month. But doing it more than once. And one of the things, if you were looking at this pretty closely, you can see that we haven't done a lot of real in-depth validation of these tools. And part of the reason is that actually does require a lot of time, and it's a more expensive thing because you need to do it over time. You need to follow out, measure outcomes, and you know that's a more major undertaking. But you know we need to do it.
So someone asked a question about Sue Weller. I think this was in reference to concept mapping. Do you have maybe one of the references you can send us can be your favorite reference for concept mapping?
Okay. Well, there's actually a concept mapping paper that I can't remember if Russ was involved with that, but there is a D&I, Weller Romney 1988. So maybe somebody's found it. I think there's two things you want to learn about concept mapping. One is just the mechanics of it, and I suggest you go to the website. The company, some of you may know Bill Trocum, who is an evaluator and methodologist, was up at Cornell. He invented concept mapping many decades ago and presumably made a lot of money out of it. But there's a book, and there's the software system. There's a lot of support on how to do it. And then there's just examples of papers that have been published, substantive papers that use concept mapping. And I think if you have a couple of those examples and some documentation on how to do it, and I'm happy, I will look and see if there's like one really good, easy to get paper, and I'll send it along.
That would be wonderful. Thank you. So then there are also some questions about what's the context in which you would use this, use your tools. In what settings is it appropriate, or maybe more importantly, have you ever found a circumstance in which it didn't work or wasn't appropriate or needed to be adapted so much that it was unrecognizable?
So, and you're talking about specifically sustainability assessment.
Yes.
Well, I think where I wouldn't use it is when people really aren't, when what they're talking about isn't sustainability. And again, so I'll just tie two things together. Some of you may know, there's NCI has funded a set of P50s on implementation science, and you all have one as well as we do. And we're doing a concept mapping project on use of methods in implementation science. We're trying to see what people think are the important methods, and then we're going to do a crosswalk on a review of published papers to see what methods are actually being done. And what's interesting to us is there's a real confusion between theories and intervention approaches and methods. And there's a similar thing when we talk about the pipeline. You know, the D&I pipeline has been so useful for me to understand what are the different phases or pieces of dissemination and implementation. But I've also found that we get confused. You know, so like Enola Proctor wrote a paper on implementation outcomes, and it was so important for the field, but it also led to some confusion around the difference between clinical outcomes and implementation outcomes. And we've tended, and I've seen this in grant applications, we tend to sort of munge that up. So my answer to that is, I think often people are more interested in implementation processes than sustainability. And just, you know, measure what you really care about and don't try to apply one thing to the other.
I'm going over the list of questions here. I think we've covered most things generally. So Amy Hubschman has a specific question about applicability. And I think a lot of us are wondering, is this the right tool for me? And so I heard you say, well, make sure what you care about is sustainability for one. But then is it the right fit for what I'm trying to do? So she talks about a project that's being implemented with a school or a school nurse. And so it's sort of part public health program and also has some intersection with clinics. I mean, would the PSAT or the CSAT, would either one of them, just based on that brief description, be a good fit? And how do you know? How can you tell?
So I'm gonna dodge this a little bit, but hopefully reassure the person with the question. One of the things we did is both these instruments are released under the Creative Commons license. And what that means, I didn't know this until we started doing it, but what it means is people are free to use these tools in any way they want. All we ask is that, you know, you cite us if you actually use it. But what that also means is there's a balancing act. A number of partners and other projects have adapted these. And in fact, one group basically combined the PSAT and the CSAT. You know, they weren't happy. And again, the people who are most likely to sort of take this and change it up are researchers, not less the community partners. Now, on the one hand, I get a little nervous because we put a lot of work into this. And I think just because you think one word is better than another word, you know, we have a lot of psychometrics that underlie this. On the other hand, that's the point, is I don't know how a tool like this might be useful in your particular situation. The other thing I would say is we have a sustainability group, and a lot of that question is very similar to questions we get a lot of. And we're happy, you know, what I would say is follow up with me. Kim Pruitt, who is, her name is on this. She's our sustainability manager. We'd be happy to talk through like particular situations. And, you know, we do have a lot of experience. So I think we could say, you know, this is a great idea. Maybe this one, think about a little bit more. But what we found, because these were designed not for nursing, not for smoking, not for, you know, it was meant that if you look at the items, you see they're not generic, but they can be applied in lots of different ways. So, but it does, okay, yeah. And please, Amy, do follow up. And, you know, because, you know, it's a little hard on here to sort of know the specifics, but we'd be happy to talk more.
Well, thank you so much. We are out of time. I really appreciate this. This was fantastic. And We will post the recording as well as the slides on our Accords website. If you need anything more, please let me know, or and I'm happy to reach out to Dr. Luke to put you in touch. So everyone, thank you for your attention, for your attendance today, and hope you have a good rest of your day. And thank you so much.
Happy holidays, everybody.